My topic is multi-drug resistant bacterial infection after liver transplantation. I will focus on impact and risk factors. So this topic itself is very important, and I am going to discuss among these outlines what is the importance and burden of the disease, that is incidence of sepsis, how it determines the post-surgery outcome, the definition of multi-drug resistance and extended drug resistance, and what about infection in cirrhosis without liver transplantation? I mean the incidence of MDR infection in cirrhosis itself before LT, and sepsis in LT recipients and their risk factors. Then I will go to MDR infection in particular, then sepsis and outcomes, and MDR organization infection and its outcome. And next I will be discussing our experience. So coming to the burden of the disease, the importance of the subject. As you know, approximately 2/3 of early death, that is within 3-month death, that is 90-day mortality, is due to sepsis. So it's predominant cause of mortality after liver transplantation. Hence, this is the most important factor which determines the course of the patient post liver transplantation. The bacterial infection varies between 25 to 60% of the patients, depending upon the center and from series to series. The incidence of MDR, most of them would report almost 1/4 of the whole infection or MDR infection. However, the incidence is increasing in recent times. The most common source of infection again varies between center to center, and the predominant source is either bloodstream, abdominal or respiratory or UTI. These are 4 common source of infection. Coming to the resistant organisms which are common are extended spectrum beta-lactamase producing enterobacterial, and carbapenem resistant enterobacterial, and the vancomycin resistant enterococci, MRSA, and Acinetobacter brahmini, that is carbapenem resistance. These are the organisms. Coming to the definition, the MDR definition is the isolate should be non-susceptible to at least one agent among the more than 3 antimicrobial categories, and this definition changes according to the antibiotics groups for different species. For example, for enterobacterial, the groups are these: if any organism which is non-susceptible to more than one agent in more than 3 groups, then should be considered as MDR infection. So extended spectrum is defined accordingly. It should be at least one agent in all but 2 or fewer antimicrobial agents. That means it's most of the groups it should be non-susceptible for more than one agent, except 2 or fewer antimicrobial categories. And PDR is obviously non-susceptibility to all the agents in antimicrobial categories, in all antimicrobial categories. Coming to source of infection, the immediate source of infection could be recipient derived or donor derived. The major factor being the recipient derived infection, which plays a bigger role than donor derived infection, which is also an important factor in deceased donor setting. But in live donor setting, obviously the recipient derived infections are more common. So infections usually that could be because of the pre-existing colonization in the recipient, or any advanced liver disease, or the recipients who are using who are getting prophylactic antibiotic treatment, either for SBP prophylaxis or prophylactic therapy and therapeutic antibiotic in the recipients before being taken up for transplantation. Regarding donor derived infection, the manipulation of the organ in the time of at the time of procurement and till the time of implantation, that also determines where we are getting the infections. Organ preservation fluid can keep the microorganisms alive, and obviously the source being the liver which has been retrieved, and the decontamination during the whole process that determines that plays a role. So coming to multi-drug resistant bacterial infection in the liver transplantation setting, what are the factors that comes into play in these patients, in these patient groups? As you can see, the prevalence of MDR infection according to this review article is 20 to 30%. The risk factors that are important in this setting are MDR infection which is present before liver transplantation in the pre-operative period, the MDRO organization colonization, recent or ongoing long-term antibiotic therapies, be it prophylactic, be it therapeutic also. Indwelling catheters like central lines, venous lines, and urinary tract catheterization, and invasive procedures and any prophylactic therapy, they are all important risk factors to determine the post-surgery MDR infection. And at the same time, the factors which plays a role in this complex process is the timing of liver transplantation and the targeted antibiotic prophylaxis which is being given, or preemptive therapy, preemptive antibiotic therapy post surgery, and the immunosuppression and the active surveillance for infection. Whenever the infection happens, whether we treat it adequately, we escalate the antibiotics at the right time and de-escalation at the right time, that will also lead to decrease in incidence of MDR infection subsequent early post-operative period. So, in one study published in 2019, Nature Communication, they tried to look at the colonization of multi-drug, the role of colonization of MDR organisms and its longitudinal evaluation of intestinal microbiomes after liver transplantation. They looked at the risk factors according to the timeline of transplantation. One is pre-liver transplantation and during perioperative period, and post-op early and post-op late. They try to look at the risk factors which play a role in this context. So the factors which were mainly responsible are MDR organism infection or colonization which is already present during pre-transplant period, antibiotic prophylaxis, all the groups like glycopeptides, beta-lactamase and fluoroquinolones, the post-LT complications which are either bleeding or bile leak or biliary stricture or biliary problems like cholangitis and all, they usually play an important role in late post liver transplantation period. But if you look at the factors which play a role in pre-LT period, usually it is either the status of the liver disease or colonization by the bacteria, and in early post-op period also the colonization by bacteria and the antibiotic exposure which determines the role in MDR organism after transplantation. Coming to the importance of colonization, in one review article published in year 2023, the organisms which were commonly found were the ESBL producing enterobacterial and carbapenem resistance enterobacterial and MDR pseudomonas aeruginosa, Acinetobacter brahmani and Enterococcus and MRSA. So if you look at the risk factors associated with these infections, most of them would tell that if there is colonization before surgery, that plays an important role for MDR infection post surgery. Along with that, the other factors which is the most important factor is the advanced nature of the liver disease, that is MELD score, which and surrogate marker along with other markers at the time of LT or at the time of listing of the patients, and prolonged post LT ICU, post LT intubation, hemodialysis, any patient receiving dialysis, renal replacement therapy post LT, that is also another risk factor. The combined transplant like multi-organ transplant, biliary complications and rejection, they are all risk factors. But however, the importance of this article has given importance on the role of colonization as a whole plays a role in all the groups of MDR infection. Coming to in cirrhotic patients, if we look at the MDR infection in cirrhotic patients only, if we look at the risk factors, one study I would like to quote, which is from India itself, PGI Chandigarh. The MDR colonization in this study, they included 125 patients. They looked at the MDR colonization in particular at the time of admission and at post admission day 7. Out of all patients, they are all cirrhotic patients. 60% of the patient had ACLF according to them. 80% of the patients had MDR organization colonization, and 20% of the patients, out of them 20% were pan drug resistant also. The colonization sites were rectum, nose, skin and central line. And the precipitants of acute liver decompensation, the cause of decompensation, nerve fluxus and prophylaxis for SBP, and infection by MDRO before that hospitalization were risk factors which determined the incidence of MDR infection. The MDR colonization, especially at the multiple sites, in that is a risk factor for MDR bacteria infection. Along with that can lead to multi-organ failure and mortality. In that, even the MDR organization infection affects the mortality in patients who are not for transplant, in liver cirrhotic patients only. Coming to donor-derived infection, like I discussed, which is also an important factor in deceased donor setting, though its role is in live donor setting would be very negligible. So this is one study which is published recently, 2019. They included, it's a multi-center study from Spain, and included 622 solid organ transplant, all transplantation included. They looked at the prevalence of culture positive preservation fluid infection, which is alarmingly 62%. However, if we look at the high risk of pathogenicity, only 25%, and the incidence of rate of preservation fluid related infection that were ascertained in that study was not very high, 1.3%. However, that is also another source of infection, just to highlight. Coming to, since it appears that there is a difference between deceased donor transplantation and live donor transplantation, that the infection rate would be different, but the studies I went through, one review article published in year 2021, with a huge number of patients in each arm, they didn't find much difference between the incidence of infection between both the groups. They are saying it's almost the similar kind of infection, and the risk factors being almost similar. So this is one study. Now I will go to the pre-transplantation factors which are important for infection itself. I am not talking about MDR here. This study predominantly DDLT patients, and the indication of transplant being SCV related and ALD related cirrhosis. 30% patients had infection. So the infection incidence varies between maybe 25 to almost 60% in most of the series. The patients with post-transplant infection had longer hospital stay and mortality. And even infection presence and infection post-LT, that affects the outcome, mortality and hospital stay and cost, the burden to the hospital, the cost burden to the patient. The pre-LT infection and more than 2 days of mechanical ventilation before surgery were risk factors according to this study. Coming to MDR and non-MDR infection, this study, which was specifically for live donor liver transplantation, published in year 2017 in Liver Transplantation Journal, 223 adult patients. The most common indication for transplant in this group was primary sclerosing cholangitis. Almost 37% of the patients had PSC as an indication. 122 patients developed infection within 1 year. Since the predominant group is PSC and they were anticipating the biliary complication as one of the cause of the infection, so they had a longer follow-up and to look at the various bacteria which are involved in this cohort of patients. The Enterococcus species was most common frequent pathogen that was identified, and 25% of the patients had MDR organism infection. Coming to the risk factors they found which were of importance in this cohort were MELD score at inclusion and recurrent infection within previous year, that means before LT, Roux-en-Y anastomosis and acute rejection and biliary complications. Because this is a separate cohort of patients, so Roux-en-Y anastomosis and biliary complications were also came out to be the important factor for MDR infection and infection as a whole. This is another study which specifically looked at the infection, bacterial infection prior to liver transplantation, how it affects the post liver transplant outcome, published in 2023 recently in JHEP Reports Journal. Good number of patients, 466 patients, all are DDLT patients. Pre-LT infection were present in 108 patients, which would be approximately 22 to 25% of the patients had pre-LT infection. As you can see, majority of patients had SCC as an indication to go ahead with liver transplantation. MEL sodium mean was 20 plus minus 9. 30% of the patients experienced in perioperative period new infection. The most that is post-LT infection rate is 30% in this cohort. The most frequent site of infection in these patients were intra-abdominal, that is almost 44%, and bloodstream infection, pneumonia, chest, and urine being on the other sources. 25 pathogens were MDR infections, 17 which is 17%. The most common organism being enterococci, and most common the MDR being ESBL enterobacterial. So this is the cohort between controls and pre-LT infection group. As you can see, the new infection post-LT were more common in patients who had pre-LT infection, and bacterial infection post-LT also were more common in who had pre-LT infection. Along with that, fungal infection was also more common in pre-LT infection group. And ICU stay and in-hospital stay were more in patients who had pre-LT infection. So they also looked at the risk factors which determined the post-LT infection in two models. They found that pre-LT infection, alcohol-related cirrhosis, are either high MEL score at the time of liver transplantation or ACLF at the time of liver transplantation. They had got increased odds ratio. But if you can see, the pre-LT infection has got highest odds ratio according to them. Coming to in their supplement table, they provided the data on MDR infections. So this is microbiological categories characteristic of post-LT infections. The common organism being gram positive and gram negative organisms. Among the MDR infection, ampicillin resistant and methicillin resistant MRSA and ESBL enterobacteriaceae were common infections. If we categorize them into no MDR and MDR infection, which is 81 patients and 25 patients, they didn't find any difference between these two groups according to this study. Pre-transplant multi-drug resistant infection in LT recipients. This study is the study published recently in 2024 from Brazil. The effect they specifically looked at the effect of MDR infection in pre-transplant period and its effect on the incidence of MDR infection after transplant and its outcome on survival. They identified 351 infections that was involving 259 patients, almost 30% of the patient of a cohort of 865 patients. 91 of those 351 infections were MDRO infection, that is 25%. And of those MDRO infection, almost 30% patients had more than one organism involved as a MDR organism. The most common organism in their group were the Klebsiella pneumoniae. The most common MDR organism that was responsible were ESBL enterobacterials and carbapenem resistant bacteria. Total these were pre-LT infections, the MDR categories of pre-LT infections. Coming to the post-LT infection, 214 patients, almost 25% patients developed infection by MDR organisms after LT, and 35 of them had MDR infections before LT, which is approximately 16% of those who had MDR infection post-LT. The common organism after LT were carbapenem resistant enterococci in their cohort. The risk factors which were responsible for pre-LT MDR organism infection, MDR organism infection, were SBP prophylaxis, cephalosporin use or fluoroquinolone use, ACLF patients, and length of hospital stay before LT. And SCC were protective in their cohort. Obviously, SCC patients being less advanced, having less advanced liver disease, they were protective. Coming to 90-day mortality after liver transplantation, what they have found that patients who had high MEL at inclusion, which is not there, I should have included that, And MDR infection, organism infection before LT, were a determining factor, along with surgical time more than 450, which is more than 7 hours approximately. And MDR infection after liver transplantation was not a risk factor, as you can see here. However, if MDR is because of the gram-negative bacilli, that were determining the outcome in the patients. And dialysis, any patient requiring dialysis and early retransplantation had higher 90-day mortality. So MDR organism infection, according to the most of the studies, except that study published in 2023 in JHEP reports, they affect the post-transplantation outcome. That is particularly early post-transplantation mortality, that is 3-month mortality. If you look at the curve of survival, the MDR organism infection, who had pre-transplant, this is pre-transplant MDR organism infection, that were determining the post-LT outcome, 90 days outcome. Coming to another study which were published in Journal of Hepatology, this study particularly looked at MDR bacterial infection after liver transplantation and looked at the risk factors and its impact in post-transplantation outcome. Good number of patients, 960 patients with 1045 liver transplantations. The bacterial infection occurred in 41% of the patients. The common source being respiratory and UTI and bloodstream infection. The organism which were common in their cohort were enterococci infection, E. coli and Pseudomonas infection. They found that nosocomial infections were more frequent than community acquired infection. Community acquired infection were defined by infection which is happening within 2 days of admission. This is the MDR pathogens were isolated, the post-LT infection were isolated in 21.6% of the patients, which is almost 53% of whole infection group. That means almost more than 50% of the infection were by the MDR organism. If you look at the source of the infection, overall infection group, the common sites were the respiratory infection and UTI, urinary tract infection and bacteremia. And among them, the MDR organism, if we look at them, then the common sources were UTI and respiratory infection and bacteremia. Coming to the multivariate analysis of development of MDR bacterial infection in their cohort, they found that the number of blood transfusion and MDR infection, bloodstream infection before LT, within 3 months of LT, and ICU admission within 3 months of LT were important factors. And ICU admission had got highest odds ratio in terms of risk factor for post-LT infection. If independent predictors of 90-day mortality, if you look at it, then antibiotic therapy before LT and ICU stay and retransplantation patients and patients who had MDR bacterial infection before surgery, they had got highest risk of 90-day mortality. The odds ratio being highest for MDR infection before transplant. Looking at the impact of survival, the in between infection and no infection group, the MDR infection group had high risk, had lower survival in comparison to patients who had either no infection or infection by susceptible organism. So these are the studies which looked at the adult patients. The pediatric group of patients, I didn't find much evidence regarding MDR infection in particular. In one study published in 2020, they looked at, this is a retrospective study, 118 patients. 96% of this group, this is from the study from China, they had 96% LDLT and that live donor transplant. They found that almost 62% of the patients had MDR GNB isolates, Klebsiella pneumoniae being common organism, and almost 17% were carbapenem resistance organism too. The median time for MDR organism infection were day 9, and they found that it affected the outcome in pediatric liver transplantation patients, also decreasing the survival. Looking at the risk factors, what they found is the use of antibiotic use within last 3 months of liver transplantation and operation time and length of ICU stay were risk factors, with exposure to antibiotic being highest risk, having highest risk. And when they looked at carbapenem resistant enterobacteriaceae infection in particular, they found that high PEL score were also another risk factor for MDR infection. So coming to ILBS data, this is up to 2021 data. 578 patients were included for a research project by one of our students. The common source of this is for preoperative infection. The common sources were blood, urine and sputum, and ascites, that is SBP, being one of the common cause of preoperative infection. Coming to post-LT sepsis, the post-LT sepsis, the common sources are the bloodstream infection, followed by the abdominal ascitic fluid or drain site infection. Urinary sepsis and chest are also common sources of post-LT sepsis. Looking at the sepsis related outcome in those cohort of the patients, the infection rate of infection between the patients who had infection within last 1 month and who had infection beyond 1 month, and or else who never had infection, those patients, the infection rate as such were not much different between both the groups. However, those who had infection, they had higher risk for septic shock and that is severe sepsis and 3-month mortality and 3-month mortality related to particularly to sepsis. They had higher risk. We didn't look at the MDR organism as such and its impact on post-LT outcome. However, we tried to identify how many organisms were MDR in having post-LT sepsis. Among them, the source where bloodstream infection were more common, sorry, followed by the drain or ascitic fluid infections and respiratory infection. If you look at the MDR infection among all organisms, this is alarmingly high in our setting. Almost 53% of the patients had MDR infection among the 164 samples that we have analyzed. And if you look, if we include even extended drug resistant organisms also, then almost 70% of the infections are not susceptible in our group, which is quite alarming. And we are yet to analyze the MDR, the prevalence in pre-LT patients. To summarize, the risk factors which is associated that can be recipient related predominantly, donor related has got negligible impact in live donor setting. The MDR colonization is the most important risk factor for post-LT infections. Based on current level of evidence, however, most of the guidelines they do not recommend decolonization. Rather than they give importance on going for transplantation in right time without letting the patients to have advanced liver disease and to have multiple hospital admissions and requiring antibiotic prophylaxis and all those things. So those are the main target areas which we should be looking at. Because decolonization in most of the study, they didn't find any significant difference in between post-LT infection or outcome, and that's why none of the guidelines they recommend pre-LT decolonization in these patients. The other risk factors being high MELD score, antibiotic prophylaxis, and pre-LT hospital stay and ICU stay and antibiotic therapy. And MDR organism infection decreases post-LT long-term and short-term survival both by according to the most of the studies. Thank you.